And that's the goal, is like 10 minutes or under for floor EKGs, or is that just an ER thing?
No, that including the floors. So that's why like the night shift person, there's only one night shift individual at a certain time. So then they're in charge of the whole hospital.
Well, to alleviate stress, there are some orders that are routine, and that is not within the 10-minute mark.
Okay.
So you could, if you have stat orders stacked on top of routine, you get your stat orders first before the routine
So
orders.
like a pre-op EKG somewhere else in the hospital would be like a routine one.
Yeah,
okay. Typically. But there has been times where like an order says routine, but you have to, the indication for that routine order is chest pain. Now, using your clinical judgment, should you be grabbing that EKG? Probably, right? Just because it says routine doesn't necessarily mean that, okay, I can kind of chill, I can wait. If you see that indication saying like, oh, it's for chest pain or it's for SVT and stuff like that, but they accidentally put it in as routine.
Yeah,
like it's your job as the clinical professional to kind of decipher like what's important and what's not.
Right.
Because at the end of the day, you're probably going to get that call 2-3 minutes from now from the nurse saying like, hey, I just put in a stat EKG for chest pain. And it's like, oh, well, I'm like 10 minutes late now.
Right.
So.
Okay. Do you guys get in trouble for not meeting the metrics?
Sometimes.
Okay.
We do. It hasn't been pushed a lot lately. I would assume because we've met the criteria and we've been all doing pretty good, and we do have a pretty good team.
Right. I imagine as long as you're falling in that like bell curve of like, well, Sean usually gets them done on time, so if he misses a couple here and there,
I don't know what we do now, but back then we used to be able to. We used to know our averages, our average times. And there has been times where I go up to my lead and be like, hey, I want to know like how I'm doing, like what's my average and stuff like that. It used to be like a month basis of like what our averages will be. And typically those averages are broken down in the ED because those are typically a little bit more important than the ones on the floors. So we try to average out like what the ED wants, and that's good for you guys as well because that goes to your guys' manager as well, and it kind of gives us them an idea of like, hey, like our guys are doing okay because we're two different departments, right? And there has been times where like management has, dogged on us and be like, hey, what's going on? Why are these like EKGs like patient adore EKG, right? Why has it been like 10-15 minutes? Why hasn't it been grabbed? And then we'll go into it and be like, yeah, the order hasn't been placed in. That's why.
Right.
So like it is important for those kind of aspects of kind of like understanding, like making sure that everybody is doing their job. Because if at that point, if you guys are not doing your job correctly, then you guys need to be like informed as well, but vice versa. If we're not doing it correctly, then we need to be notified these kind of statistics as well.
Yeah, I try to be mindful of the EKG order because sometimes, usually how it works is the EMT puts in the order based on the chief complaint when they check in: dizziness, shortness of breath, chest pain. Kind of no-brainers, they all need EKGs. And so sometimes when those ones slip in and they don't put in that order, that's often where I'll miss it because it's usually there. So I always try to double check and be like, did an EKG actually get ordered? Because every now and then those ones will slip through if the intake provider assumes that the order got put in but it didn't get put in.
Well, not just that as well. A lot of the times patients won't admit anything until they see a provider.
Sure.
Right? They'll just come in and be like, I just don't feel right.
Yeah.
Right? And then they'll come in, and even in the intake, they'll go into a room and they're like, oh, by the way, I've been having chest pain, or I've been peeing blood for the past like 3 months. Right? And then they're like, well, why didn't you tell us about this beforehand?
Right.
So like that kind of puts a stop on your guys' plans as well.
Yeah, it's often you ask the patient what's going on and they're like, I feel terrible, or you tell me. I'm like, well, what symptoms are you having? And sometimes they don't understand, like, we need to hear the symptoms. I don't need you to tell me the diagnosis of what's going on. I need you to tell me what symptoms you're having.
Yeah. And I think that's important for us as our role. I get that we can't diagnose anything, but when it comes to cardiac things, like we are allowed to ask, like, do you have any history? Are you having chest pain right now? Is that chest pain radiating anywhere? Are you having jaw pain? Like, we can ask those things. Anything further from that, that's beyond our scope of practice. We can't do that. But I know some providers do like to get a history, and some providers just want to see the EKG. And knowing your team, like, they'll be like, hey, like, this is a new sudden onset of AFib. Like, this is brand new for them. So asking those things for you guys as well. I don't know if you guys don't dislike that or not, taking that
I think
away
it'd probably
from you.
be a little provider dependent, like how much. It probably depends on how much they know you too. If you're a EKG tech I've never seen before in my life, and you come up to me and you're like giving me a whole spiel, I'm kind of like, okay, But knowing you, I'm like, okay, I want to hear the additional details you got, especially when it's a patient I don't have in front of me, or
Right.
I feel like more details the better.
Typically, whenever you got when a patient already has seen a provider, I don't usually ask those kind of questions, because at that point it's redundant. Right. There's nothing is getting achieved. Right. So I want to make sure that the patient is up to speed and doctors are up to speed of kind of like what's going on.
Right.
Yeah. It's usually in the case of like the patient's coming from intake, and then we have to find a provider in the back
who
to get
definitely
the EKG.
hasn't seen
exactly.
them. Yeah. And I know it's one of the frustrations is like you're finding a provider in the back, may or may not actually end up being their patient. They're looking at this EKG. They don't know what the chief complaint is. They don't know what the patient looks like. And so sometimes if you like launch into a long spiel about a bunch of stuff, they're like, I may or may not actually care about this, depending on if it's going to be my patient or not. I might not even need to know these details. They're usually overwhelmed in the back.
Yeah.
So I'm sure it's kind of provider dependent how they handle the stress of having to sign dozens of EKGs. That
know your people, right?
Yeah.
Know your providers. Everybody is different. You want to make sure that the workflow is the best. And typically, if it's like you would come in with the patient's EKG and you're like, it has a history of this, and it's like a totally normal EKG. Like, obviously, like, okay, so like that doesn't really matter. But like if you do see something really abnormal, there has been times where like the providers are like, whatever. Like, but then I'm like, hey, you need to honestly like take a look. It's totally different from the EKG prior to this one. Right. Please look into this one. Well, and more times than not, it does grab their attention. Right.
Well, you recognize when it's a more pertinent EKG than when it's not. If it's a normal EKG, we probably don't need a whole spiel. But if you're like, it's AFib with RVR at a rate of 180, they probably need to come back sooner rather than later.
Which did happen to me at one of my shifts. He had a new onset of AFib, and he didn't have a history of anything cardiac related, and he had a very high heart rate, and I showed it to the doc, and it was kind of like pushed aside, and I was like, no, this is very new for the patient. Right. So then he ended up having to get more urgent care. Yeah.
I think what gets brushed by a lot are pace rhythms, because typically the pace rhythms for the summary, it just says like AV atrial sense V paced, right? And it'll just say like no further interpretation. Yeah. Right? Because at the end of the day, you really can't, because it is a paced rhythm. But then like I'm seeing like something that's like failure to sense, right? And then I'm just like, okay, well, if you can look into that, because at the end of the day, when they see this and they're like, okay, it looks fine because it's V paced. It's important for us as well to kind of notify those kind of things to them and be like, hey, I don't know what's going on with these pacer spikes. I don't know if they're real or not, but the patient does have a pacemaker. So,
and some people on the provider level just need to understand it's part of our job. Like, we have to learn to stop whatever task we're working on to deal with signing an EKG or putting in an like, we get interruptions throughout the day. It's just a skill you have to develop to be like, now I'm moving my brain to analyzing this EKG. Now I'm moving my brain to putting in this Zofran order that nursing is requesting, or ordering pain meds. We get interruptions in our workflow throughout the day, and it shouldn't be just this frustrating thing. Yeah. It should be something we just
and not to like
used to.
Put too much on APPs, but I believe that APPs should be able to analyze EKG rhythms and be able to sign them, because it is a lot on doctors when they have to get all the EKGs.
It is. I kind of agree with you, but at the end of the day, it's the provider's job. Right?
Yeah.
I mean, if you guys want to help out with the providers, and that's on you guys, then I would be great for you, the doctors. That would be great for us.
It is provider's job, but we're all a team.
We are.
Yeah. So it would help doctors out a lot because APPs do work with the doctors. So if there was an EKG, an abnormal EKG, an APP could sign it and then just made the doctor aware that this EKG has been abnormal.
Yeah, and we've crossed that road. Like, because I agree with you guys. I feel like the APPs should be able to, if you don't feel competent, get competent enough to be comfortable signing EKGs. But I think it's one of those things that probably varies from hospital to hospital. I mean, there's some hospitals where there's only an APP covering an ER, way out in the middle of nowhere, and they probably do have a level of comfort looking at an EKG. But in our system, I think it comes down to the fact that we have so much resources and there is an ER physician always there. They're like, liability wise, they're like, we just need to put this in the physician's hands. So maybe that'll get revisited one day. I don't know. Because I agree. I think the APPs should have, especially the ones that work in intake, they're trusting us with the responsibility of putting in orders, determining a priority if a patient needs to go back or if they can wait. This is just another level of determining patient prioritization. But yeah, it's one of those battles that probably varies from hospital to hospital.
Yeah.
You'll probably see systems where APPs do routinely sign, but maybe that's not the normal standard. I don't know. And that could be why we get a lot of pushback having APPs sign the EKGs. Because we can certainly analyze them, but it's that like signing, no STEMI thing.
Yeah,
For some
and the
reason has
confidence.
everybody.
Because at the end of the day, it's your call.
Yeah.
Right? And I do get it. Like, some people can't take that responsibility.
I think it would take, if one STEMI was missed, it would probably be like, well, we're not having the APPs do this anymore.
That's why a lot of these rules kind of apply, right?
Yeah.
Because if there's a brand new, terrible, shitty rule, right, it's probably because somebody effed up. Right?
Yeah, and for all I know, for all I know,
and it only takes one person. And it's vice versa with us, right? That's why we have to document a lot more thoroughly. I mean, typically we were supposed to, but it hasn't been really pushed on because somebody missed a really abnormal rhythm, the STEMI, and it was missed and nobody documented it. And that has happened to me before, and it sucks because it doesn't matter. You're your own person, and people will point the finger all the way back down to the tech.
Yeah, that's true.
There has been a time where I was in one of the vascular units, and it was one of my morning routine EKGs, and I was like, that looks like a STEMI. And it was that great. It was that period where like shift change kind of occurs. Mm-hmm. So like I told the night attending nurse, and then I was super busy that day. I should have sat down on the computer and notified, documented, like I collected an abnormal EKG during this time, right? But I was so busy, and I was like, it's vascular. They know their things. And I got a call like 3 hours later. They're like, did you grab this EKG in this room? And I was just like, oh, the STEMI? And they're like, yeah. Did you notify anybody? And I was just like, oh, shoot. And it was Charge that called me. So then, at the end of the day, it turned out that like the hospitals didn't agree that it was a STEMI. And then cardiology did their rounds, and they're like, that's a STEMI. Like, what is going on? And then hospitals blamed them, and then blame me, and then it came back to me.
I imagine in the hospital itself, like not in the ER, that just gets way more convoluted because there's so many physicians involved with their care.
Yeah.
The physician may or may not be anywhere nearby the patient, whereas in the ER, it's kind of like if there's a questionable STEMI, we can just message the cardiologist, and then boom, the definitive person who's going to say yes or no has already said yes or no, and you're kind of covered if something's delayed.
So now, anytime if I see like an abnormal EKG, and when I mean by abnormal EKG, I'm not talking about like bundles or stuff like that.
Right.
I'm talking about like a sudden onset of AFib or like RVR, a block, right? Anything that's somewhat abnormal, you got to cover your butt, right? You got to document these things, and I think that's super important that we do document these things. Same thing with doing those walk-in outpatient EKGs.
Yeah.
You got to. I think we should push like knowing those protocols of like signs and symptoms of fib, signs and symptoms of a heart attack and stuff like that. And if we do see like a super abnormal EKG, we have to notify the provider. But what if the patient is having like signs and symptoms. Like a bunch of our techs don't really know what to do at that point, right? I've been in the field a little bit longer, so I have a general idea of what to do. I can kind of figure out what to do, but I think that needs to be pushed with our group as well. And
well, covering your butt is an important tip, I think, because I mean everybody throughout, regardless of your role in the ER, that's what everybody's doing. We're putting the patient as number one priority. Like the nurses will come to us and say, hey, their blood pressure's looking a little bit soft. And we're like, yeah, but looking historically, their blood pressure's always pretty low. But the nurse documents like, hey, made the provider aware of this. This isn't just getting, ignored. So that way they're covered if the ER provider's not taking it, immediate action on something because they're not worried about it. Everybody needs to document, I think, those types of things.
Yep.
Let's see. Do you guys have any good patient interactions that have stuck with you, or any interactions that either good or bad that have kind of been with you for a while?
Yeah, I did have a patient where she was going through it, and I think that was like her last day at the hospital. And I went to go grab an EKG, and her husband was just talking about like, this is not the life we wanted for each other and all that, which she was of age and she was getting a lot of treatment. And so it was there. And then come later on, I had to grab a repeat EKG, and the husband did make the decision to pull the plug. And as I was like grabbing or trying to grab the EKG before the nurse came in and told me that we didn't need it, she was just like holding onto my hand, which blew my mind because she didn't have enough strength to eat or say anything, but she had a really firm grip on my hand as I was holding it. And it's really sad to see.
Yeah.
But, and I do kind of like agree with the husband. Like I wouldn't want my last days to struggle in a hospital bed.
Right.
Yeah. So that really stuck with me.
Yeah, those are hard things to see because we deal with that so much in the ER, where they're like, you want to do everything for the patient, you want to keep doing tests and interventions, and sometimes they decide, nope, that's it, we're done pursuing medical care. Whether you agree with it or not, it's always hard.
Yeah, it's the patients or the advocating their decision.
And regardless of your role too, like, because even if you're with the patient very briefly to do an EKG or scribing for them or whatever, it still kind of sticks with you. I mean, there's so many patients in the ER that I'm just kind of peripherally involved with, or I didn't spend that much time at the bedside, but it still kind of sticks with you.
Yeah.
You're like, gosh, that case was really sad and depressing.
Oh, yeah.
And even though I wasn't at the bedside for a half hour digging into the emotions with the patient, it still kind of goes home with you.
Mm-hmm.
One thing we talk a lot about on the podcast is like avoiding burnout, and burnout's a factor in every role, regardless of how much time you spend with the patient. Do you guys have any ways that you deal with burnout?
I personally like going to the gym and decompress.
Yeah.
On days I don't work and I don't feel like going to the gym, I just like to sit in my house with my dogs and just relax and just have that day to myself.
I'm kind of a weird case. So we have a very high turnout rate, and we do have, especially exercise physiologists and EKG techs, it is very high burnout. It's very repetitive. It can be tough to climb up in the career ladder. So I do understand individuals getting burnt out. Personally, for me, I'm the type of person that don't really mind doing monotonous things. If something is, I wouldn't say per se easy, but if it was, I can't really imagine what you guys go through.
Yeah.
So for me, I'm the type of person that tries to not stress over the things at work into my day-to-day life.
Yeah.
That's why I tell you guys, I'm up till 12 or 1 every morning and then go to work. It's because I truly want to do the things that I want to do at home. Me getting stressed out at work, that's not going to achieve anything. Right? Because at the end of the day, how the patient sees you react, they're going to get stressed out, and then it causes all sorts of other trouble. So, going to the gym, I fish, I hike, I hang out with friends. I think that's a really good way to kind of decompress, and don't bring that stress and energy like to work, because all your peers see that, all the patients see that, especially patients like they catch on like immediately what your reaction is. And there has been times where like I kind of see like a really weird EKG and I'm like, oh, and then they immediately freak out. And then so you can't bring that energy, that stressed out energy. And like I just tell people, like, if it's stressful, like have the stress here a little bit, but like don't bring it back to your lives. Then it's just going to be a domino effect.
Yeah.
Right.
Usually with patients, I like to go in and try to joke or have some banter with them if the atmosphere allows for it.
Yeah.
Because it's just like you're already so stressed with the patients, or the patients are so stressed and very nervous about being in the hospital. So I like to joke with them to like ease the tensions a bit.
Yeah. That's what I do. You guys already probably know my really stupid personality. I try to leave a positive atmosphere. Sometimes it bites me in the ass, but at the end of the day, like, it's all about timing, right? Joking not only with the patients, or like having a little bit of laughter with the patients, but with your peers, right? Because if you bring that energy, that positive energy to the workplace, everybody's going to feel a little bit better.
Yeah.
Joking around, because like that's what I try to tell new hires a little bit, is don't stress over the little things, right? These guys are dealing with something, right? And if somebody kind of snaps back at you, like, don't take it personally.
Yeah.
Right. Everybody has their job to do. Don't stress over those things. Or like if you miss an EKG, there has been times where like I missed one stat EKG and it's like 15, 20 minutes late. I'm like, shit, right? If I'm freaking out over that thing, then I start to miss everything, and that's when the whole flow kind of falls apart.
Yeah.
So like at the end of the day, just call in, be like, hey, like, sorry I missed it, or like try to make the environment or the atmosphere a little bit better. Talking with patients, don't take too long, obviously, but like, you know, joking with them, trying to make them feel better.
No, that's a great tip, because I feel like it's easy. There's lots of little things throughout our day where you're like, you could let it hang over you the rest of the day. You could be like, I missed that EKG by a few minutes, and then it just affects your workflow the remaining rest of your shift, instead of just letting that go and realizing that we're all human, we're all imperfect. You know, everything's not going to go perfect throughout our day, and letting that go so it doesn't affect the next patient encounter. Yeah, it's a good tip.
It's very big.
Yeah, and like, you know, so everybody is stressed in the ER. We're, you know, we all try to be the calm in the chaos, like you said, with EKGs. Like, the patient's already freaking out. I'm not going to walk in and be like, why isn't this EKG done? Holy shit, they're having chest pain. Get it on them. Give it to me. You know, like, that's not going to help the patient at all.
No.
Even when they're having a STEMI, you know, usually my line is like, hey, you know, your EKG looks very concerning. I'm worried you're having a heart attack. So you're going back to the next room we have available.
That's like what I love to see, is that when a patient does have like a STEMI, a VT, or an SVT, we are so calm.
Yeah.
And I see the providers there very calm, and it's really nice to see that.
You have to be.
Yeah.
You have to be calm, because like that because your brain's a very powerful organ, and however you feel
yeah,
up
how you
there,
perceive everything.
like everything is just gonna get worse. So like blood pressure starts to rise up, and you're having a STEMI, right? Then you're adding more stuff to it, and it's just gonna cause so much issues. One of my best lines that I like to do is, even if it's a good EKG, and they're like, how does it look? And you're just like, well, I'm not the doctor.
Yeah.
I can't tell you. And they're like, but it's my body.
Right.
And I was like, I don't have the $300,000 piece of paper.
When I hear the
I
patient,
can't
when
do
I hear that
Yeah.
happen with the patient, I try to like go look at it real quick so I can tell them like, hey, it actually looks very reassuring.
Yeah.
You know, this is half the puzzle. We still got to look at labs and things like that. But I try to, like, when they're really worried about not getting that answer right away from you guys, I try to go in and look at it real quick to reassure
Yeah, I
them.
usually tell the patients, like, that's why they get their big paychecks. Is
That,
why they tell you.
Or not necessarily diagnosing anything, but to kind of reassure them, and I'm just like, well, do you see me walk away?
Yeah.
And they're like, yeah. And I was just like, I'll let you piece that together.
Yeah, if you see me sprinting
If you see
away.
me running away with the lead still on, then you can piece that together.
Right.
So trying to reassure them, while at the same time not to be that person that's diagnosing everything. again, makes patients feel a little bit better, a little bit less concerned.
We always had that debate on the ambulance when we had a STEMI in the field. Do we go lights and sirens back to the hospital when that's probably going to kill more heart tissue when they're in this anxious state and we're rushing? And it all depends on how far away you are. Are we going to actually are we going to save 10 seconds and risk all of our lives by hauling ass back to the hospital? Or are we going to save 10 minutes by, running a bunch of red lights to get to the hospital? Maybe it's worth it if we're saving 10 minutes, but are we only saving a few seconds while the patient's heart rate is escalating and they're more anxious and more heart tissue is dying on the way to the hospital versus a nice, calm, let's treat your pain, we'll give you some aspirin. There's going to be a lot of stuff going on as soon as we get to the hospital. So that was always like the debate is it worth going lights and sirens while everyone's amped and the patient's amped all the way to the hospital for a STEMI, or is it worth it or not?
Yeah. And you gotta, because there's already a lot of chaos that's already happening and ensuing. So using that comic relief sometimes with your peers or with the patient, it kind of brightens up the mood a little bit. And typically, if you're in a better mood, you'll be able to think more rationally. You'll be able to...
Oh, definitely. You got to handle your stress.
Exactly. And I think a lot of people, especially people our age, right? The younger crowd, they don't really know how to deal with those high stress jobs. And I don't think it's that bad, especially in our situation, since we do have so many resources. Yeah. That's what I have to tell a lot of the people.
And that's with when I was scribing, it was so stressful, but you have to manage it because then your notes just fall apart. Because you have to, it's like a step-by-step process. You have to do this, all within seconds of seeing the next patient. So when you stress, it really just goes downfall.
Yep, you're less productive when you're stressed out, right? You don't think rationally. You're going to miss a lot of things. And even when you're interpreting the EKG, right? And you're just like, oh, fuck, I got to go to the next patient. And then next thing you know, it turns out that the patient is having a super abnormal EKG, but you just gave it up, right? So it's important that you kind of get calm, recollected. I have no issues whatsoever when I have a coworker saying can I please have a 30 or can I please have a 15?
Right.
Yeah. Sure. Absolutely. Yeah. I prefer somebody that can recognize that they do need to decompress. If they do need to eat, they need to sit down and relax a little bit. That's not going to offend me whatsoever, because I prefer that versus people that are actually stressed out. They're burning out, and that's making more work for me, right? Because now not only I have to do some of their stuff, but now I have to kind of calm them down, right? Yeah. So I'm working
fix the situation.
Exactly. And at the end of the day, I try to be it's not the end of the world, right?
Yeah.
It's okay.
Yeah.
Right. If it happens, it happens. The patient's not dead yet, right? So at the end of the day, you want to try to trying to make sure that everybody is in a good, positive atmosphere.
Well, it's not your emergency, right? That's one of the tenets we all try to live by is this is not your emergency. And if you see it as your emergency, you're much less help to the actual patient. If you're getting amped like they're getting amped, you're not nearly as helpful to them as if you can be that calming presence. And